Thank you very much for inviting me to speak to you today. So the title of my talk today is 3D printing in congenital heart disease: who, how, and why. And I thought that this would be an interesting topic to talk about, since in recent years I have used it heavily, which has probably transformed some of the lives of some of the patients, and will probably change also some of how we deal with some tough congenital heart disease patients. So I have no disclosures. And if I ask you a provocative questions, knowing what you know today about patients, which would you prefer to have for your patient? Is a single ventricle pathway, as in what we see here? There are two ventricles, but the patient was routed because the previous surgeon decided that is a complex heart to be septated and would be routed into a univentricular repair, as you would see here, or would you rather have a congenitally corrected transposition physiology where the right ventricle would be the systemic ventricle and the left ventricle would be the subpulmonary ventricle? The answer to this is not so easy sometimes, and for that, we could actually look at some of the data to tell us what is best for what. If we look at the survival of the Fontan procedure, you would see that it is not really great. A lot of the patients who had older Fontans have trouble now, and they will continue to have trouble because of the imperative of having a systemic venous hypertension. And that even does not include the operative mortality that we always see initially. And if you look at once they develop the either protein-losing enteropathy or some of the other complications of Fontan's, their survival becomes so detrimental that it actually there is a substantial mortality thereafter. And if you look at those patients specifically with heterotaxy, they don't fare well after the Fontan procedure. And so if we look further into how Fontans fail, the problem with Fontans, when they fail miserably. They don't fail just like heart failure. No, they fail with protein-losing enteropathy. They fail with plastic bronchitis, thromboembolism, with arrhythmias, pacemaker, reinterventions, hepatic fibrosis. So there is a substantial morbidity that comes out with their failure. So it's not just a failing heart. No, it's a multi-system failure. And therefore, if we're able to avoid those patients, then it's better, or that type of physiology, then it's better to go and avoid that. And you've seen this is the freedom from any reintervention after Fontan procedure. Majority of the patients will need something done to them. So the Fontan is not a final operation. They will always need further interventions. Now, on the other aspect, if we look at those patients who've had a systemic right ventricle, which is what is present in a congenitally correct position, so there is a double discordance. There is an atrioventricular discordance, and there's an ventricular arterial discordance. So we have the right ventricle pumps to the systemic circulation. If we look at them and how they fare, these are the patients who could be, whom we are going to mimic if we septate these complex ventricles and put the right ventricle in the systemic circulation. So these are like those patients who've had a mustard procedure for DTGA, or those patients who've had a physiological repair for congenitally corrected transposition. And you know what? Their survival is reasonable at 30 years even. Therefore, accepting a right ventricle to become the systemic ventricle is not a bad option on those patients compared to those patients who are routed into a univentricular repair. This is where the 3D printing really came in, at least when I started at the Cleveland Clinic. We thought that, you know, those patients have been routed into a a single ventricle because the surgeons felt that it's not routable. And the best way of actually looking at those patients is when you can handle the heart in your hand. And if you look behind me here, actually there are a number of hearts that have been printed that I'm actually looking at. And I thought there's nothing better than actually holding the heart in your hand and you're able to see and turn around the heart in your hand and be able to see it and be able to judge exactly how you're going to do. And I'm going to show you some of these videos of how we evaluate these hearts with the use of 3D printing. So it is not new. 3D printing has been started in the 1980s, and it came about at the time of the inkjet. Instead of having ink on a paper, it's a material that is actually layer by layer, and this is how it looks. It's a program, and there are actually materials that are different kinds. And I'm not going to go into the details. It's not in my area of expertise anyway, but I get the end product. So this has been in the 80s and 90s have been developed. And then it came about that it's being used also in medical practice. They engineered even some of the organs that is not yet in clinical use, but this is how it's being developed. And so far, we are actually devising these entirely printed devices that can be implanted into the human beings. And that is being used now actually in some of the medical specialties like plastic surgery, orthopedics, maxillofacial surgery, as you see, replacing the jaw and so on and so forth. So this has been going on for some time, but in congenital heart surgery, it's fairly new to actually use this in devising newer operations. So why do we need 3D in medicine? Actually, it can be used for education. So, and I'll show you an example of that, how you could actually show the fellows and residents of how you could do an operation by looking at these devices. And I'll look to, you could actually use it for surgical planning as I've been using it, and I'll show you how. And it can be actually used also for medical devices, and it can be used also for parents. So you can actually bring the actual model, show it to the parents that they could see what does it mean to do this procedures or these procedures, complex procedures. So in complex heart, achieving a biventricular repair, and that's what I've mainly used these.
I am just on a, I'm going to try to turn it down so I can hear you better. Sorry.
Am I okay to continue? So using a 3D printing in complex congenital heart disease is really to achieve a biventricular repair on those patients who have been deemed unseptatable or unrepairable. So they have left being into single ventricular repair. These are the patients with heterotaxy or with double outer right ventricle and a remote VSD, which they thought that it's not routable to the aorta, abnormal situs, abnormal heart position, also crisscross hearts, univentricular hearts with unusual anatomy, abnormal systemic and pulmonary venous connections, and their relations to each other with respect to the AV valve. So these are just some of the examples, and it can be actually more than this that can be used for the 3D printing. Now, in medicine, how do we actually generate the 3D prints? You start off with an imaging study that you feed into an additive manufacturing. I'll show you that. And then you would get the product. And there is a difference between additive material versus removing material. That is the additive versus subtractive manufacturing of a device. And you could virtually have unlimited geometry that you could produce with this. It's all about how much granular you want to go with these devices and how much you could print, and this is what happens. So we start off with either a CT or an MRI imaging that is acquired just normally. And then we take it and we do a 3D reconstruction and a special software that also colors these different organs, and that's why we're able even to, when we print them, to color them, to we're able to see which is which. And then we have a digital preparation for these devices, and then it is transformed into another software where you could produce the 3D model. That this is the time engineers would consult me. At this time, they would say, how do you want this heart? These colors are good. Where do you want us to cut the heart before we print it? And then it goes into the printer. And this is how the printer actually goes back and forth and puts in different layers of this material that it comes out as a solid block of material or organ. But then it goes through a post-processing after. You see, as you see, this is the organ is being built based on the computer. And then what you get is you get this, and then you get post-processing. After that, you melt all the other structures, and then you end up a structure like this with cavities that you could actually see on the inside. This is what I was saying when you could teach the fellows and residents of how you do surgery. This is like a transposition of great arteries that that can be used to teach them how to stitch, how to transfer coronaries, and how to do the procedure before they get into the operating room. I'm just going to stop this for a second. So the evaluation process that I do here when I get a patient with a complex heart, and this is one of the examples that you'll hear now, that he's being routed to a univentricular repair because he just was felt too complex to be routed. And that's why the problem, obviously, he came with a failed Fontan. So let me just play that video for you, and then we'll talk about it after. I just want to make sure. Were you hearing the narration on the video? I just want to confirm that.
No, we're not.
Oh, okay. So if you were not hearing the narration, then I need to explain that, because that's what I was wondering. Okay, so let me start again here. So this is a patient who basically has a congenitally corrected transposition and is being routed into a univentricular repair, as you would see here. So with a congenital transposition, double outer right ventricle. So this is the left ventricle, this is a right ventricle, this is the aorta coming out of it. And this previous surgeon felt that it's not possible to route this left ventricle to the aorta because the V is far. Therefore, he was routed into a univentricular repair. And that's what happened when. So when we open this model, and this is an exact replica of the heart. We open the model, we see that there's a VSD, and this is actually routable to the aorta. And at least I could see before surgery, this is what I'm going to do. And I was able to route the patient into it. So the first step in the evaluation of the process is, can the LV be the systemic ventricle? And can we actually route the LV to the aorta? And if that's what it is, then that is what the patient will get, is basically have the left ventricle pumped to the aorta. But if not, then could we actually use the right ventricle to become the systemic ventricle? But this is what happened in this patient. So this is basically what happened. He's had a previous gland. This is his SVC, IVC. And this is his basically used, both ventricles have been used as a one pump. And this is the aortic valve. His pulmonary valve had stenosis, and they did that. So this is basically his circulation before he came to us. And this is his return from the single ventricle to the from the pulmonary circulation to the single ventricle and then outward through the aorta. And this is what we did to convert him back into a biventricular repair. I left his SVC connected to the right pulmonary artery, moved his IVC into the right ventricle, and then did a right ventricle to pulmonary artery connection and routed the left ventricle into the pulmonary circulation. Thereby, he had a septated heart with the left ventricle being the systemic ventricle. Then subsequently, what we do is to look at the systemic and pulmonary veins. So these are connected, especially in heterotaxy, in different areas. Sometimes the systemic veins mixes with the pulmonary veins, and sometimes there are some anomalous drainage in both the systemic and venous aspects. And this is where the 3D printing, because it gives us the spatial relation of these veins in relation to the atria. And that's why we're able to route them into the respective ventricle. Wherever that ventricle we choose, whether it's the right or left, we have to route the appropriate venous structure to that appropriate ventricle. And that's another example of that. I want to ask again, are you hearing the narration or not?
No, we can't hear that.
I'm sorry. I'm just going to continue with this one. I guess it's, so basically this patient has had 5 previous operations before, and unfortunately, can you hear me now? You couldn't hear me either.
No, it's not sustained that we're able to hear it.
Okay, so I'm going to skip these videos because it doesn't look like it's coming out through the computer. So I should have probably, when I signed on, there's a choice that I should have done. I'm sorry for that, but we'll go through the process here. The third process for evaluation is to evaluate the atrioventricular valve on the choice of the ventricle. So again, these are, you could have common AV valve, you could have separated AV valves, and then with that, you got to route the appropriate valve to the appropriate venous drainage. So, and that's where also the 3D printing helps. So if we have an atrioventricular septal defect, which is a common AV valve, we're going to separate these two into 2 valves. And the choice of which ventricle pumps you want the better of the 2 AV valves to be the systemic AV valve, because if you have a bad AV valve, this is like the mitral valve. If it's bad, that means you're going to end up having systemic AV valve regurgitation, which will mean that the patient is not going to do well. Therefore, when we evaluate the septation, that complex septation with a 3D printing, we got to actually choose the valve that is good for the systemic circulation. Not only the size and the function of the ventricle, but also the size, the function of the atrioventricular valve, which can be detrimental in these patients. And we've done some of these complex rerouting specifically only to address the AV valve to make sure that we are routing the appropriate venous channel to the appropriate ventricle and with the appropriate AV valve. And I'm not going to go through this again. So this one is actually an interesting patient because I want to actually explain. This one is a 30 years old patient. I do have the surgery after this. So I'd like to explain a little bit on the 3D print. He's got bilateral SVCs. He's got a hepatic vein separate from his IVC. So we've got 4 veins connected to the atrium. And he's got total anomalous pulmonary connection that is draining into the left superior vena cava. And then he's got a common AVSD and pulmonary stenosis, quite complex. 30 years old, never had surgeries before. Unfortunately, because he was very blue and people thought that he's not suitable for anything, he ended up having a stroke because of the cyanosis and the high hematocrit. So he came to us after actually recovered from his stroke and asking whether we could do something for him. When we printed his heart, and I'm going to just run this quickly so you could just see this heart. It's a 30 years old, so you would see basically this is the structure of his heart: bilateral SVC, common AVSD, 2 large good ventricles. The pulmonary veins drain into the left superior vena cava, and then you got hepatic veins and IVC opening into what is the right atrium. So what we've decided is that we're going to septate him and do the procedure that we've called a ventricular switch procedure, where we use the right ventricle to the systemic as a systemic pump, and the left ventricle as a subpulmonary pump. Therefore, so the first thing is we septate the AVSD, and then we take out these pulmonary veins that they were attached here to the left SVC, and we attach it to the right atrium. And then we septate, bring in the IVC and the hepatic veins to drain into this the left ventricle. And then we do another connection between what will become the systemic ventricle and put a conduit to this into the pulmonary artery. So this is quite a complex internal rerouting, and we could have only done that, or possibly even done that, with the 3D help. This is the actual operation. So I'm gonna just run you through this. This is like a 5-minute procedure. I prepare these conduits in the back bench before we do the procedure, and I do this because it is the best way of actually judging. So I don't put homographs because this can be really as long as I want and with the size I want it. This is the patient as we've just seen the 3D prints. 2 vena cava here and 2 SVCs here. Now the patient is on pump. This is basically, we divided the main pulmonary artery, and this was stenotic. The pulmonary valve was overshown. Here we're looking at the inside of the heart. We're dividing. This is the common AV valve that is it's got a superior and inferior bridging leaflet. This is a very large inlet VSD. So now we're going to divide this into an anterior and posterior valves. And this is basically a patch that has been cut to appropriate dimensions to close this area. This is closing. This is the inferior bridging leaflet. This is the inferior bridging leaflet. We have to make sure that we avoid the conduction system, which is displaced posteriorly. Now we divide the superior bridging leaflet. So now if you imagine the systemic veins, this is IVC and hepatic veins are here. And the SVC, there are 2 SVCs in there. So the orifice, the posterior orifice that you would see here will be the right-sided valve. And the anterior orifice will be the left-sided valve. Now this is a large patch of autologous pericardium that will be put in here. So what's going to be is good, the atrial septation, or what we call it the atrial conversion, a large patch. So what's behind it is the systemic veins, which will go into the posterior orifice. And the pulmonary veins are going to be connected to the right atrium, and they will go into the anterior orifice that connects with the aorta. So So the pulmonary veins would drain into the anatomical right atrium, which becomes effectively the left atrium, and into the right ventricle and into the aorta, thereby is septated, but in a congenitally corrected transposition type of physiology. This is basically just to take the redundancy from that patch. So now we're testing this valve. This is going to become the systemic AV valve. Now we're coring out the left ventricle to conduit. This is the conduit that I prepared in the back bench. And this is basically sitting behind the heart. Now we're going to connect the pulmonary veins that have been anomalously connected to the left SVC. We're going to connect them into the right atrium. So it's pulmonary veins, it's going to be right atrium, but effectively it's actually anatomically right atrium, but physiologically it's the pulmonary vein atrium. So pulmonary veins into the right atrium, into the right ventricle, to the aorta. And now we're just closing the right atrium. And now we're translocating the right SVC into the left SVC. So now because obviously the right SVC, if we lift it connected to the RA, it's going to become an obligatory shunt for the pulmonary circulation. You don't want that, obviously, otherwise the patient will be blue with the SVC draining in there. And this is the final stage of that operation, which is basically connecting that left ventricle to the pulmonary circulation, where we've completed and septated that ventricle. The patient came into the operating room with a saturation of 75 and left the operating room with a saturation of 95 after the septation. And we're just now removing the clamps. This is how the LV, the pulmonary artery conduit, looks, and how this is the heart looks after we came off bypass. So it is quite complex, but we could only achieve this with the 3D printing. There are some other uses also for the 3D printing, like changing the dynamics. So we could actually look at this reoperative surgery. We could do print the pulmonary artery itself and the pulmonary valve, and even on the bench, we could actually do this inflation of the balloon on a 3D printed model. And you could see now, you'll see the stent being inflated. So you would see exactly what this is. You see the stent being inflated. So you would judge exactly what happens. And if you're gonna, this is from my colleague, Dr. Phillips. And if you have an abnormal shape of a right ventricular outflow tract, and you have, so balloons and stents are circular, you could actually put in a device that will occlude part of the abnormal shape, and then you eventually end up with a circular shape that you could actually implant a stent into it and avoid stent or paravalvular leak. I've got only a few slides left only, and there are very few studies which shows the efficiency or need for the 3D printing. And this is one of them. Basically, they've introduced the 3D printing to a surgical group where the congenital heart surgeons, and they've asked them some questions in between the different stages as they've had the conventional surgical plan, and they've asked them some questions, and then they've done the 3D printed model, whether that has added to their knowledge, and then subsequently they've had their final approach and what they have done, whether that has been affected by the presence of the 3D printed heart. So just looking at these are the different anatomies or congenital malformations that have been seen. And this is how they've gone through the stage one. So this is the first stage where they've had the conventional plan laid out. This is the conservative management on those patients who've had the surgery. These are the surgeries which have been performed. And if you look at this, these have been conservative. That means that they've gone a single ventricle, or they were left without their balance